Now I'm going to be performing the Watson test. So we're getting into some wrist and hand special tests. So for this test, I'm going to bring my patient into slight ulnar deviation and some slight wrist extension. I'm going to locate the scaphoid, and now I'm going to apply some compression to that. And now I'm going to actively move or passively move my patient into radial deviation as well as some wrist flexion, and this is considered positive if you feel the scaphoid clunk or dislocate. Now I'm going to perform some load and shift of the scaphoid and lunate. So what I'm going to do, come down the middle phalanx, we find capitate, go a little bit to the ulnar side, and I have my scaphoid because you can just find that through the anatomical snuff box. And I'm going to come in, and now I just create some shear in between the two, and this is considered positive if you feel some hypomobility, and also if it reproduces the patient's complaints. Performing the finger extension test. So you have your patient's hand or fingers off of the plinth. I am going to stabilize at the wrist, and then I'm going to apply some resistance just below the MCP and ask my patient to try to push her fingers into extension. This would be considered a positive test if it reproduced the patient's complaints that they came in with, possibly indicating some instability. Here I'm performing the Lickman test. So I'm going to go down the middle phalanx, and I'm going to locate the capitate, and now I'm going to put some pressure on that and axial load it, and we're going to go go into radial deviation and then into ulnar deviation. And this would be considered a positive test if the capitate subluxed and jumped into our fingers, which can indicate some instability. I'm going to perform the shear of the lunate triquetral. So I'm going to come down middle phalanx, find capitate, come over, get our lunate, and then to find the triquetrum, it is right on top of the pisiform. So you just find the pisiform and come over, and now we just create a shear between these two carpals, and again, it is considered positive if there is a reproduction of the patient's complaints that they came in with. Now I'm going to be performing the test for the anterior interosseous nerve. So what I'm going to have my patient do is make an OK sign with both of the tip of their index and thumb touching like that. And let's say, for example, the patient's sign or could only do OK, and it looked like this. That would be a positive sign because it looks like a teardrop, and that would indicate that the anterior interosseous nerve was compromised. Now we're going to be performing the elbow flexion test, and what I'm going to have the patient do is kind of make this type of movement, and you hold that for 3 minutes, and we're looking to see if they get any reproduction of ulnar nerve paresthesia. And to further sensitize this test, she can be like this, and then also abduct her shoulders. And this is testing the cubital tunnel, and again, positive if we're looking for ulnar nerve paresthesia symptoms. Now I'm going to be performing the last test for the cubital tunnel. I'm going to passively kind of have my patient's arm in some flexion. She's relaxed, and I'm going to come in, and I'm just going to tap right here at the cubital tunnel, and we're looking for any reproduction of that ulnar nerve pain. And also we tap 6 times for this test. Now I'm going to be performing the bicep squeeze test, which is looking for a possible bicep rupture. So I have my patient, their arm is over here, nice and comfy. I'm going to come from behind, and I'm going to come to the distal part of her upper arm right here. And now I'm just going to provide a squeeze, and this test is considered positive if there is no movement below the bicep, because if the tendon is intact, we should see a little bit of a supination or a slight twitch. So now I'm going to be doing the 3-cluster test for lateral epicondylitis, and first I'm going to start with the Cosen's test, which is going to be, I'm going to bring my patient into elbow flexion, and then I'm going to have them, I want them to resist or try and bring their wrist wrist into wrist extension while I resist it. This is considered positive if it reproduces that lateral epicondyle pain. And now I'm gonna stretch them and put them into wrist flexion. And again, this part is Nils test, and it is positive if it reproduces the lateral epicondylitis pain. And now of the second phalanx, I'm going to resist at the DIP and resist wrist, DIP extension. And if that reproduces the lateral epicondyle pain, that is considered positive. Now I'm going to be performing the moving valgus stress test. I'm going to bring my patient out here like this. I'm going to pull them now as I extend their arm. I'm going to be creating a valgus force at the elbow at the same time. And if the patient has that reproduction of pain between 120 and 70 degrees of flexion, this is considered a positive test for instability. Now I'm going to be performing the milking maneuver. So I'm going to passively bring my patient to here, 90 degrees of elbow flexion, and I'm going to grab her thumb, and I have her elbow supported, and I'm going to bring her back like this into a little bit of external rotation. And this puts stress on the valgus portion of the patient's elbow, and a positive for this is increased laxity or ulnar-sided elbow pain. And also the milking maneuver is testing the posterior band of the UCL. Now I'm going to be performing the valgus and varus stress test, which are testing instability at the elbow. So for the valgus test, I'm going to put my patient in about 20 degrees of flexion, and then I'm going to stabilize and hold the forearm for her, and then I'm going to apply a valgus force at the elbow, and this is considered positive if there is increased laxity or ulnar-sided pain at the elbow. And then for the varus stress test, it's pretty similar. I'm going to stabilize, but instead I'm going to apply a varus force, which would be positive if they have radial-sided pain or any laxity on the lateral side of their elbow. Now we are going to be performing, and I'm going to be instructing my patient on some carpal tunnel testing. First, we're going to perform Phelan's test, where I'm going to have the patient kind of do a prayer sign, but upside down, so elbows flexed to 90, like this. And then you hold this for 60 seconds, and we're looking to see if any median nerve complaints come along, and that would be considered positive. And now we're going to do the reverse Phelan's test. So now it's going to be the prayer position up, and again we're going to hold this for 60 seconds to see if median nerve complaints begin. And now we are going to be doing the hand elevation test. So I tell her kind of look up like a ballerina, and she is going to hold that. And again, we are looking for median nerve distribution pain. And now we are going to do the carpal compression test. You have your patient in supination. And what I'm going to do is provide a dummy thumb on the median nerve in the carpal area. And we're looking for median nerve pain distal to that compression. We hold this for 30 seconds and we look for that median nerve distribution pain. And lastly, we are going to do the Tinel sign at the wrist. You're going to do this multiple times. And we are looking for any reproduction of that distal median nerve pain. Now I'm going to be performing the ulnar impaction test, which is looking at possible TFCC lesion. So I'm going to have my patient elbow flexed on the plinth, and then I'm going to come above. I'm going to stabilize her wrist, and I'm going to bring her into some ulnar deviation, and I'm going to apply an axial load, especially through the 4th and 5th MCP. And again, this would be positive if there is a reproduction of ulnar-sided pain. I'm going to be doing the TFCC load test, which you can do in conjunction with the previous test. So again, I'm going to have my patient in some ulnar deviation, and then I'm going to load. And now that I'm in this position, I'm going to kind of grind the patient into flexion and extension while in ulnar deviation, and this is considered positive if it is a reproduction or pain within the within the ulnar side. Now my patient will be performing the supination lift test. So we have her elbows at 90 degrees, and she is just going to perform an isometric elbow flexion with her palms in supination and push up on the table. And this would be considered positive if she has any reproduction of ulnar-sided pain and could be a possible indication of a TFCC lesion. Now I'm going to be performing the ulnomeniscal triquetral dorsal glide, and what I'm going to do is locate the triquetrum and the distal ulna, and I'm going to perform like a pinching mechanism, which this is looking at a possible TFCC lesion. So again, we know our triquetrum like that. And what I'm going to do is stimulus, and I'm just going to perform a pinching motion. And this will be considered positive if the patient is experiencing ulnar-sided pain. Now I'm going to have my patient perform the press test, which basically she's going to be performing a tricep dip. And this test is looking at a possible TFCC lesion, so perform that movement. Good. For this test to be positive, she would have ulnar-sided complaints. Now I'm going to be performing the UCL stress test at the thumb. So what I'm going to do is stabilize the CMC with one hand. I know it's hard to see it. Stabilize the CMC with one hand, and then I'm going to have the other hand 30 degrees of flexion at the thumb. And then when your hand is stabilized, if your thumb goes into more than 30 degrees of flexion, it can be indicative of a possible tear, and that would be a positive sign. I'm going to be performing the piano key test, which is looking at bone and joint integrity. So what I'm going to do is I'm basically just going to press on the distal ulna, and this would be considered positive if it's a reproduction of the patient's complaints and pain that they came in with. Now I'm going to be performing the ballottement test. So I am going to stabilize the distal radius, and now I'm just going to create some shear here between the distal radius and ulna, doing some AP and PA glides. This would be considered a positive test if this reproduced the patient's complaints that they came in with, and again, this is looking at bone and joint integrity. I will be performing the thumb CMC grind test. So what I'm going to do is apply a axial load at the CMC joint, and then I'm going to kind of go into some rotation at the CMC while compressing this joint, and if it would be considered a positive if there's any crepitus or cracking or any reproduction of the patient's complaints that they came in with. For the Allen test, it's looking at vascular filling time. So what I'm going to do is my patient's in supination. I'm going to locate the median and ulnar arteries, and I'm not going to compress them yet, but I'm going to have my patient open and close their fist 5 times. On the 5th one she holds it, I have both arteries compressed, and now I'm going to let up on the median artery, and I'm going to watch to see the color refilling. This should refill in no greater than 5 seconds, and now I'm going to come back and I'm going to compress and ask her to perform that again. Hold and then relax. And now I let up on the ulnar artery, and I was looking to see how long it took, venous filling time took in the ulnar artery distribution. And again, we're looking for that coloring to come back up, and that shouldn't take any longer than 5 seconds. And if it does, or you just don't see the color, it's taking forever for the color to come back, that could be indicative of whichever artery that you let off of is compromised, and it's not, there could be a vascular issue at hand. Now I'm going to be performing the Frohman's test on my patient, and that is looking at the ability of the adductor pollicis. So what I'm going to do is I'm going to place this, and I want my patient to do radial adduction, which is like this motion. I'm going to put a sheet of paper here and ask her to hold it, and don't let me pull it out. So this is good. It doesn't look like her adductor pollicis muscle is compromised, But if you can notice that if the adductor pollicis is compromised, that they will use their flexor pollicis to try and keep hold of the paper, so it looks more of like this, like that, to hold on to the paper instead of this, and that would be considered a positive sign if you see that compensation. Now I'm looking at the integrity of the extensor hood. So I have my patient at the edge of the plinth, her hand hanging off. She has her PIPs and some slight flexion. And now I'm going to provide resistance below her PIP and ask her to try and extend her fingers. This is again looking at the integrity of the extensor hood. If I didn't feel any resistance, that could be, or any extension at the fingers, that could be indicative of tendon tear or compromise of the extensor. Now I'm performing the test that's looking at the integrity of the flexor digitorum superficialis muscle. So what I'm going to do is we're going to focus or isolate the middle phalanx. I'm going to hold down these fingers and hold down right here to isolate, because I want her to perform PIP flexion. And so because she can do this motion, that shows that the FDS is intact. And now we're still going to isolate the middle phalanx, but I'm going to come down and hold the others down, and I'm going to ask her to flex this finger, and I'm looking here at DIP flexion. Good. And that is indicative that the flexor digitorum profundus is intact when the finger is still able to flex at the DIP part of the finger. We're doing the Finkelstein's test, which you would do if you were maybe thinking that your patient has some de Quervain's or a tenosynovitis. So I'm going to have the patient tuck her thumb in and make a fist, and then I'm going to bring her into ulnar deviation. And this would be considered positive if the patient says there's some reproduction of pain here in the snuff box region. Now I'm going to be performing the Bunnell-Littner test, which is looking at capsular tightness or versus intrinsic muscle tightness. So say I'm going to do it of the first phalanx. I have the wrist in neutral. I'm going to stabilize the MCP, and then I'm going to check how much flexion I can get at the PIP with the MCP stabilized. So we get a good amount, and now I'm going to put the MCP in some flexion, and now I'm going to perform PIP flexion. And it looks like we get a lot more. So because we got a lot more with the MCP flexed, it shows that the patient's finger is having more of some intrinsic muscle tightness versus joint capsular tightness. Now we're doing the Haynes-Zancali test, which is pretty much looking at the same thing as the test before, except this time I'm going to stabilize the PIP joint, and then I'm going to flex the DIP joint. So we see she doesn't get a lot of flexion here at the DIP, but now let's say I flex the PIP. Let's see how much motion she gets at the DIP. All right, it's not a lot more, but she does seem to get a little bit more with the PIP flexed, which that again is going to point to more retinacular tightness versus joint capsule tightness.